So great. Welcome, all of you. This is the 47th Pain Journal Club. And today we are going to discuss a very important topic, which is part and parcel of our daily practice. And we've got some very good discussions planned ahead. So let's begin now. I'll just make my presentation full screen. I hope you can see my screen now. And we start with the theme exercise in low back pain. And this is, I repeat, 47th Pain Journal Club of the Mumbai Pain School. Before we begin, just the customary introduction. Pain medicine world over has got a lot of diverse issues. It is practiced in different ways in different countries, and there are variable standards. Different learning requirements are there, and as a result, there are different offerings. Money and time are limiting factors which prevent the physicians from getting a world-class education. Mumbai Pain School is an initiative by Panisha Spine Wellness and Pain Relief Center in Mumbai. And we are using the online media like Facebook, Instagram, Twitter, and other social media to create awareness as well as to impart quality training to the physicians who have special interest in pain. So we have most of our content is online and it is on demand, just like Netflix. We have got both the free and paid content. Most of our content is free. We're also having hands-on workshops. The recent of, the last one was held in month of December. We are fortunate to have received support from expert faculty from all over the world. And it is said that the best teachers, they teach from the heart and not from the book. What's a journal club? It's nothing, it's just a club, with the only difference being that we critically evaluate recent academic literature, which is based on a defined subject. And attendee participation is very much valued. So I request all of you to participate, ask questions, comment, suggestions, healthy criticism, everything is welcome. So we encourage attendee participation. Please feel free to ask any questions. This is the St. Bartholomew's Hospital in London, or the BARTS, which was the venue for the first documented journal club by Sir James Paget. Across the Atlantic, Sir William Osler started his journal club, where the cost of the journals was what prompted him to start this journal club. Even Harrison had his own journal club. He at one point of time he held that every 15 days. And the purpose was critical evaluation. Time and discipline is extremely important, so we'll try to stick to the timelines. Healthy skepticism or praise is most welcome and appreciated. This is a bit about me, the key being that I am a spine and pain physician and I practice exclusive pain medicine in Mumbai. So today we have with us our faculty, Dr. Shweta Kolhatkar. I'll take the pleasure of introducing her to you all now. She's done her BPT and MPT. Her MPT is from the United States. She's also a certified yoga instructor. She's currently pursuing a DPT from the A.T. Still University at Arizona. And she's a senior physical therapist with more than 12 years of experience. She's currently practicing in Pune with the home health as a home health physical therapist. She brings wellness and promotes physio yoga with her workshops and classes. She is specialized in working with geriatrics and women health. She is also yoga certified. You can reach her on myphysioyoga.in. So just let me check whether she's joined in. Yes, she's joined in. So I'm just, Dr. Shweta, you can quickly say hi to all of the viewers.
Hello everyone. Thank you, Dr. Sidharth, for a warm welcome, and I'm very happy to be here. Thank you so much.
Thank you. So let's move ahead with the rest of the presentation. I'm going to take a short presentation on exercise in low back pain. And this customary introduction, which I started since the last few talks, it talks about the topic in brief so that you have an introduction on where we are going. So why is it important for pain physicians? So exercise is extremely important for pain physicians because number one, we need to understand when to conserve. There are many situations when we would rather want to conserve a patient, uh, rather than doing a procedure for them. And exercise is the number one tool, which I think most of us now understand, and we can very well relate to it. Pre and post treatment, exercise again plays a very, very important role. And it is all scientifically proven. I'll just clear in my presentation. In addition to it, it gives a better understanding of the patient's conditions. Many times the patients come with multiple issues, and it's better that some of them get sorted out. Exercise also gives a physician some time so that he can have another look at the patient on a different day, and probably his if his pain is consistent, then decide to go ahead with the treatment plan. So when I say exercise, you know, dictionary meaning is very different, but in reality, it may mean almost anything. So how the definition is quite vague, and many professionals, patients, individuals, they use this term in a very different manner. So by dictionary, it means an activity requiring physical effort which carried out to sustain or improve health and fitness, blah, 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 blah. So in addition, it can, so this is a literal meaning, but the point here is that it entails some form of physical activity to sustain or to improve health and fitness. So probably there are definitions, but these are the dictionary meanings. Let's see now what it means to your patient. And for this purpose, I have quoted a very special paper, which I found extremely important. And they have listed a lot of different types of exercises which play a very important role. And I suppose all of us should know that. So we start with this particular form of exercise, which is a resistance exercise. So herein, as you can see in the picture, a resistance is provided to the movement of the body muscles or parts. And by definition, it is mentioned as exercise training designed to improve the strength, power, endurance, and size of the skeletal muscles. So this is the same resistance training which is usually done in the gyms or in to get that elusive physique. Moving to the next form of exercise, we have stabilization or motor control exercises. So herein, the training targets specific trunk muscles in order to improve the control and coordination of the spine and pelvis. This is a very special form of exercise because they target multiple groups of muscles and also improve the control of the patient's brain over these structures. There has been very recent interest in many of these activities, and many of the apps, especially in this part of the world, they are focusing on this form of exercises more and more. Moving on to the next part, this is Pilates, or mispronounced often as pilates. But if you see, this is another form of exercise training which follows the traditional Pilates principles such as centering, concentration, control, precision, flow, and breathing. So it's a complex set of exercise in which a lot of coordination is required in a particular manner, which is described in the principles. Okay, so we move to another popular form of exercise. So I'm talking yoga is a lot of things. You have yam, niyam, asan, pranayama, pratyahar, dharana, dhyan, samadhi, and So you have different parts of yoga, but I'm talking about the physical component here only. So exercise training following traditional yoga principles with a physical component. So this is what we mean when we are talking about yoga as an exercise. McKenzie approach and McKenzie exercises are well known. So this is nothing but exercise training following the traditional McKenzie principles, such as repeated passive spine movements and sustained positions performed in specific directions. The key is to centralize the pain, and all these movements are taught in different ways, and slight variations are not uncommon. I will recommend that all of you should read at least what is McKenzie method, and this particular link from Physiopedia will describe it in great detail. So I recommend that you should just go and read this for greater understanding. Another form of exercises is flexion exercises, which can be a combination of resistance and flexion exercise, but can be pure flexion exercises as well. So this training consists of controlled movements in flexion only. Then we move on to the next type of exercise, which is aerobic exercise. And this involves exercise training such as walking, cycling, and jogging, and any land-based mode that is designed to improve the efficiency and capacity of the cardiorespiratory system. So this involves the cardiorespiratory system in a bigger way. Okay, so we will be discussing more on the paper later on. Moving to the area of recent interest, now we have the water-based exercises, and this include the exercise training which is performed in deep or shallow water, and this has evoked recent interest. Stretching is also a form of exercise. Earlier it was recommended before the exercise. Now currently it is recommended after the exercise. So you do a warm-up before and stretches after your exercise, but it itself is a form of exercise. It includes muscle lengthening using any of the methods like passive, static, isometric, ballistics, or proprioceptive neuromuscular facilitation. So there can be various types of stretches which can be done, and you will find in many programs this is a very important, or rather let me say in most programs it is one of the very important components. In addition to this, there can be some very varied sort of programs and all new fancy stuff. So it is usually classified, I'll just put it miscellaneous, but just if I have missed any other category. So it does not meet any of the specified types of the exercise training which I have mentioned above in my presentation. So now what if you combine multiple exercises in a single workout or a single session? So this is known as multimodal, wherein two or more of these specific types of exercise training methods they are combined. However, they are not deemed multimodal by definition if it's only a part of the warm-up and cool down, as I have mentioned before. Now, talking about the true exercises, this is if the patient is just left to do these exercises on their own, and the types are over. Now I'm talking of the ways to do it. Where there no intervention is provided, and patient is told, okay, you do whatever you want, and based upon their knowledge, expertise, etc., the exercises are done by the patient themselves. Coming to the next thing, the therapist can assist using his hands, that is using his physical efforts, and this includes manual therapy, chiropractic, passive physiotherapy, osteopathic massage, or acupuncture as well, that is dry needling or acupuncture of various forms. Okay, if the therapist just monitors and gives just the corrective feedback, that is general practitioner management, education, or even psychological management, so this includes this is classified as therapist hands-off kind of exercises. So I've just summarized these various types of exercises and brought forth some of the conclusions which you must remember, for which there is unequivocal concordance amongst the researchers. So this particular paper is the one which I have referred to, the most quite recent paper, 2020 November. And they've concluded that active therapies like the Pilates, resistance, stabilization, motor control, and aerobic exercise training, where the patient is guided and actively encouraged to move and exercise in a progressive fashion, these are supposed to be the most effective ones. So they have concluded, and I conclude in my talk as well, that biopsychosocial is the current model which we follow. So what does that mean? Everybody knows that, it's a combination of biology, social, psycho. So what the key word here is individualized. So rather than putting all the sheep in one flock, each of the individual is identified based on their particular condition, and then they are recommended one particular exercise, and that is actual implementation of the biopsychosocial approach. It is been proven by meta-analysis and also network meta-analysis that Pilates, stabilization and motor control exercises and aerobic exercise training are the best ones, whereas the therapist hands-on treatment and hands-off treatment, they fared the worst ones. Okay, so it is quite surprising, but it is actually all proven, as you can see in this big meta-analysis. I've quoted the reference. Those of you who are interested can just go on for it. Another finding which is very well reflected in the clinical scenario, but is thought of to be a chance finding, actually it is not, is that the walking alone is extremely effective, especially in chronic low back pain. And there are multiple studies, many of them very recent, to prove this. And even a systematic review and meta-analysis has corroborated this as well. These are the references which I have quoted. And now I will request Dr. Bhushan to start sharing his screen and put up his CV slide so that I can introduce him. Over to you, Dr. Bhushan. Yes, I can see your screen now. Great. You can put up your CV. I will introduce you and then you can begin. Yes.
Thank you, Dr. Sidharth, for the introduction and for the great talk on exercise. And we can get started. Yeah.
So Dr. Bhushan has done his physiotherapy and MS, and he's done his BPT from the Manipal University in India. He's done his MS from the MGH Institute of Health Professions, Boston, Massachusetts, United States. He is currently a PhD student at Virginia Commonwealth University in Richmond, Virginia. He's an avid runner, cyclist, and aspiring baker and coffee lover. Sometime we'll definitely love to have love to taste your creations. And his research interests include evaluation of mechanisms of pain perception in patients with chronic neuropathic pain, and this is to identify and develop targeted pharmacotherapy and neuromodulation based approaches. So over to you, Dr. Thakkar.
So thank you again for the invitation and to be able to give me this opportunity to present here with a great audience. I'm looking forward to a discussion at the end. So just sort of a brief sort of motivation on why I chose this paper was being a physical therapist and being interested in pain and pain mechanisms. As you saw the evidence with exercises, aerobic exercise does have a positive effect in chronic low back pain patients, but we don't usually know what are the mechanisms that are involved in these effects, especially with chronic pain patients. So this study, as you all have probably read, it's a randomized control trial. So just as an introduction, randomized control trial is where it's the highest level of evidence that is out there in the literature when you're looking at the like scientific literature. And then you have one group that receives the exercise and the other group receives what we call as a control or a sham intervention. And when we go to the limitations later, it'll be an interesting discussion because when it comes to exercise, it's not very easy to have a control group where they are not doing anything or not. It's not like a pill, right? You just give them a medicine and then you can change the color and it becomes like a control intervention. With active interventions like exercise, it's difficult to sort of have a control group. So that is why you sometimes see effects in the control group as well. So this paper was published in the Pain Journal. It came out in December 2020. It was by a group. It was a collaboration between two university centers in Vanderbilt and Rush University here in the United States, led by Brule et al. I kind of just wanted, this again are some stats about chronic pain here in the United States. So here, at least in 2019, 20% of the population here in the United States experienced chronic pain. That is 1 in 5 patients commonly complained of chronic pain. And low back pain is also one of the most prevalent causes of musculoskeletal pain in the United States and globally. And we all know the amount of expenditure in terms of the health and the burden on the health systems with low back pain in terms of the care and also the surgeries as such. And especially when you look at the United States with chronic pain, there's also the link with opioids and the opioid crisis and the opioid addiction and the overdose. And since the last 2 decades, the United States has been battling the overdose crisis, but especially last year because of COVID and 2020, we had, like here in the United States, there was a maximum number of deaths, almost 100,000 deaths because of the opioid and overdose. So a lot of research focus has been on developing interventions which are sort of non-pharmacological and, trying to sort of avoid these and control the opioid addiction and the opioid crisis, because opioids are the first sort of pain medication that is also given to a lot of patients. At least 20 to 30% of patients of chronic pain are on opioids too. So this is covered with Dr. Sidharth did a very good job. Is physical exercise is an important component of management in chronic low back pain. And there's a lot of, approaches, as he mentioned, on how to treat low back pain, depending on the classification of low back pain, depending if it's an acute or if it's a chronic condition, and then what is the diagnosis also. So here today with this study, they focus specifically on chronic low back pain, and they were interested to look at what are these mechanisms, as I said, that contribute to pain relief. And exercise-induced hypoalgesia is related to the exercise-related increase in pain tolerance. So you all have probably heard about what is runner's high. So it's like after an exercise, our pain tolerance sort of increases. We've always seen athletes who during the game or after the game seem to be continuing with their activity despite of that injury that they have suffered during the game itself. So in terms of mechanisms that are involved in chronic pain and also that have been shown to be involved in the effect of exercise, the mechanisms that we will focus today are these endogenous opioid mechanisms. So not going into too much detail, but the endogenous opioids are a class of peptides and different receptors which are involved sort of in this descending modulation of pain, especially because of these receptors which are present all over the peripheral and central nervous system. And they are involved in pain, but they're also involved in other like stress, reward control, addiction, and other mechanisms. So these receptors are involved in the modulation of pain, and their activity increases with exercise. So that is the one mechanism that is being seen in acute exercises, but nobody's looked at it in chronic pain patients. So these study authors wanted to look at the role of these endogenous opioid, or I'll refer it to as EO mechanisms, in chronic pain patients pre and post exercise intervention. So I kind of wanted to briefly just talk about, and I can go into later at the end if somebody's interested, but in terms of pain perception and pain modulation, when you look at this picture here, the diagram in red is the pain transmission from the spinal cord and the periphery up to the brain. So when you have the pain that is transmitted at the dorsal horn level, and then it goes up through the medulla, and then the spinothalamic tract, and then it carries either the lateral and the anterior spinothalamic tract, depending on the type of pain. And then it goes up to the somatosensory cortex, the motor cortex, and then different centers via the thalamus. Thalamus is sort of the sensory control center where the signals go up and then go into different centers of the brain. And then depending on when it gets to the cortex, then it's sort of regulated. And we focus on the blue picture on the right side, which is the descending control. So from the cortex, there are different ways that our pain is processed. So it's important to remember that we process our pain in the brain, right? So that's why the brain plays an important role when it comes to modulation of pain. So right from the cortex through its connections into the thalamus, then to the midbrain where you have regions like the periaqueductal gray matter, then coming down to the medulla and the brainstem with the rostroventral medulla. So all these centers are involved in what we call as these descending control of pain modulation. And it's important because all these areas contain all these endogenous opioid receptors, which are the mechanisms that we are talking about here. So this picture, I know it's a busy slide, but I kind of wanted to just highlight both. On your left, you can see the brain circuits, as I explained before, that are involved in this whole pain experience. And then you look at, as Dr. Sidharth said, the biopsychosocial model, where it's not just your sensory pain experience, but it also is the emotional and cognitive experience, and especially in chronic pain, which also takes over. And you can see all these centers to the left where you have these affective, cognitive areas of the brain that control the emotional response, and not only the sensory discriminative. So on your right, you can look at all these opioid receptors and the peptides that I mentioned earlier. And there are 3 classes of peptides and 3 classes of receptors, if I remember correctly. So all these are located at different brain centers and areas in the central and peripheral nervous system. And the descending modulation is where, or descending pain centers is where you have primary concentration, where the effects are seen overall. So coming to the methods, and so this was, as I said, a randomized control trial. And this is a typical diagram that you probably see in any randomized control trial with the consortium play, like the flow diagram that is described here. And then, oops, one second. So you have people who were assessed for eligibility. There were more than 500 participants who were eligible to do the study. But then out of that, 419 were excluded because they didn't meet the inclusion criteria or didn't want to participate for such a long time, because this was 18 sessions and took a while. And then they did an assessment on 117 patients. And they, after the assessment, some discontinued. And then before the lab sessions also, there were some who discontinued. So finally, they had 93 participants, and 93 were allocated randomly either to the exercise intervention, and then others were in the control intervention. So all this, you can look at it later as well. But finally, in the study, they had 38 in the exercise intervention, and then they had 44 in the control group intervention. And all these participants had a strict inclusion-exclusion criteria that you typically see with any research study. And then, so inclusion criteria was pain of 3 on 10. And then it was a crossover design with 18 sessions, 6 weeks of aerobics exercise for the exercise intervention. And then the control group was just doing their usual activity. And then all these participants were also sort of at the low level of physical activity, where they were not doing a lot of exercise during the week. So this sort of here just describes the flow chart or how the study was completed. So the study included the self-report measures at the start of the study. So I'll go into detail at the next slide with self-report measures that were completed. So we all know that self-report measures are the easiest way to get sort of a sense of a patient's pain, because they are easy, they're convenient, and you can complete them in the clinic, and it's just paper-based. So once they completed the self-report measure to get a baseline sense of how the patients were doing, then they were given this another measure, that's the heat pain stimulus, to check their heat pain tolerance. And then they were sitting in a chair again for a few minutes, and then the drugs were provided. So these drugs were either randomized, and they were either the drugs or they were also saline. So they gave the drug, then there was a rest period, then there was the thermal pain task again, and then the self-report measures. And then again, they did the drugs and then the tasks. So they did that for 4 times. So this was before the intervention, and then they did it also after the intervention of the exercise for 18 sessions. And here you can see which drugs, like the naloxone and the saline placebo, was given. Okay. So as I mentioned earlier, the outcome measures included a bunch of self-report measures, and all these self-report measures are well validated. They are used pretty commonly in any chronic pain studies. So I have an appendix slide at the end if you want more details on what these things measure, but because of time, I won't go into too much detail for now. And so the evoked pain intensity was, so when you say evoked pain, it was when you give a pain to a participant and then ask them how much did they rate their pain. So typically there are these big instruments that you can use to test the patient's pain tolerance or their pain threshold. And you can provide them like heat pain, you can provide them pressure pain, you can provide cold pain, or you can provide electrical pain as well, and get a sense of what's their pain response. So it becomes a more objective measure rather than just relying on these self-report measures. So what they did was they gave this, as I said, the thermal pain task earlier. They used this task, and then they also measured the responses on the self-report measures, which was this McGill pain questionnaire. And they didn't put a lot of focus on the heart rate measures, but they just measured the heart rate before and then during the exercise. And it's also important to remember that there's a difference between tolerance and threshold. Threshold is when somebody feels pain at the first instance, and tolerance is where you that's the maximum pain you can tolerate. So that's something just to make everybody aware of the difference between the two things. So just going over the results, this is the summary slide on the 2 groups that were involved with the exercise group and the control group, and they were not very different. You can go into the paper again and look at all the details here. And then the pain duration was similar, and the pain level was also similar between the 2 groups. So coming to what are the effects of the exercise intervention. So they did see that, where you can see clearly here, that after there was a decrease on the 0 to 10 scale of the numeric rating intensity, with it being 4.5 pre-intervention, and then it was decreasing to 3.2. And that was significantly different for the exercise group. And also the worst pain was also significantly different, and probably there was a greater drop from 6 to 4 when you look at the numeric pain rating intensity. So this was again just a graph to show the pre-post changes in the average pain and the worst pain that I just described earlier. So you can see that there's a difference in pre and post for the exercise group as well as the control group. So coming to the other outcomes that were measured in this study. So the other questionnaire, there was a McGill pain question that looks at 4 different pain outcomes: the continuous pain, intermittent pain, neuropathic, and effective pain. And even here you can see there was a drop in the scores from pre-intervention to post-intervention. So for all these self-report measures, higher amount of pain, higher numbers indicate more pain. So a decrease in pain indicates a positive response. So lastly, one of the measures that they also looked at, and which is commonly looked at in any pain study, is just asking the patient how much better do you feel after the end of the intervention. So you obviously want people in the middle. So they did see that most of the patients, at 50% of them, noticed a minimal improvement in their condition. Some 20% had much improved. And then the others were either no change or very much improved. But most of them were around the minimal improvement or much improvement. It's a 0 to 7 scale. Again, it's very subjective, and it goes from how did you feel after the intervention that you just completed, okay? So some of the limitations that I kind of want to highlight, but not go into too much detail, is also that the participants who were selected in this study, as I said earlier, they had like a pain score of 3 on 10. They also had a very low baseline physical activity level. So then you got to also keep that in mind, whether how much of our participants are at that low physical activity level where they don't do any exercise. And then also that the fact that you have the control group, which is not supposed to do anything during that intervention period. And the longer the intervention period that you have, like in these studies, it's difficult to control for that. So you cannot, once they are outside the lab, you cannot monitor a lot what they are doing at their home or wherever they are. So it's a factor that you can't really like do a lot with any exercise study, as I mentioned earlier, because the exercise is the intervention and there's no intervention in the control group. And so in this case here, blinding is also a factor that's a limitation, because the patients weren't blinded to the group, but the people who were giving the exercise were blinded. Sometimes if the patients know each other, they can talk to each other about these interventions, and then they know, or if they know what the study is about, you can see a response in their like on the self-report measures and things like that. And then lastly, going into the sample size, so they did invite a lot of people, like around 500 people to do the study, but then ended up only having 40 and 38 people, which is a good size, but it's also not a great sample size. And when you look at 100 or 200 patients that are typically needed for a big randomized controlled trial like this. And the more self-report measures that you have, the more outcomes that you have, you always have to add like 10 participants for every outcome that you measure. So it's important to consider sample size also being sort of a limitation. And I'm happy to discuss other limitations that everybody feels in the audience, what you think they could have done better. But this was just some brief that I thought were something that you can consider when you are looking at the impact of this paper, especially when you're effective exercise as such overall. So to summarize at the end, they did see that with the exercise-induced, the opioid analgesia, there was an effect in chronic pain patients because it led to changes in the pain scores and also changes in the importance of exercise in these patients with chronic pain. And then it is critical to involve both self-report measures and objective measures of pain. So this study at least had both components. So it gives us a better picture rather than just relying on the self-report measures, which sometimes can be very subjective, although they are very reliable too over time as well. The strength of a study was that it's an RCT, but with a control group, exercise physical therapy based studies are also difficult, and Dr. Shweta can also talk about it later on her experience with exercise studies in general too. And lastly, they also were interested in looking at sex differences in response to exercise and these mechanisms. We know that the prevalence of chronic pain in women is more than men. And also, in general, there are many other conditions that are more prevalent in women as compared to men. So they didn't see here a difference in responses to self-report measures, but they did see that overall to the response to exercise, women responded better to the treatment than men. So in general, just to keep in mind that when you incorporate treatments to keep a focus on, there are sex and gender differences between women and men when it at least comes to chronic pain. And I'm sure you all have seen this in clinical practice as well, but just something to consider whenever you are looking at chronic pain, both in terms of mechanisms and response to exercise. So just to bring it all together at the end, this study showed us that aerobic training decreases pain intensity and pain interference when measured using self-report measures in patients with chronic low back pain. The mechanisms involved, they focused on were these endogenous opioid analgesic mechanisms. It's critical to think about sex differences, and future studies should investigate other mechanisms as well that talk about reduction in chronic pain, and also look at other chronic pain conditions like arthritis, fibromyalgia, neuropathic pain, or any other pain mechanisms. So happy to take any questions or have any discussion. Thank you.
Great. Thank you, Dr. Bhushan. So now we are going to just let Dr. Shweta Kolhatkar do some talking. And over to you, Dr. Shweta, for any insights, any questions, any things you'd like to add, and any points you'd like to make here.
So that was a great discussion. That was a great presentation. Dr. Bhushan and Dr. Sidharth has covered a lot of topic about the chronic chronic low back pain. I personally have seen a lot of patients with chronic low back pain in general throughout my career as a physical therapist. Something that I want to point out especially is patients with chronic pain. They can have their pain tolerance grows over the years of tolerance. Like they keep building up that pain. They just basically take in the pain, and it's like a cycle. It's a vicious cycle of pain and muscle guarding, and then they don't treat it, or they keep treating multiple in different various ways, and then they just come back to their own shell. So a chronic low back pain patient can take a long time to get better, and multiple disciplines to get to get treated. So something that I just wanted to ask about the about the study to Dr. Bhushan is the evoked pain intensity. Do you think it will be more the outcome measure, the evoked pain intensity? Will it be higher, considering they may have high pain tolerance, because the patients will show high pain tolerance? Is that right?
Yes, so that's a great point. So again, with these pain testing thresholds, and as Dr. Shweta has made a great point that, and also because of opioid medications, is the pain tolerance goes up as well. So everybody can say that after I give you that heat stimulus for a few seconds, I can only, this heat stimulus you have to increase. And then the temperature increases, and somebody at 45 degrees might say that this is a 6 on 10 for me, but then somebody who's had chronic pain for a long time might just say this is a 2 on 10 for me. So that is something that it becomes a little bit of subjective, but at least you have another way of evaluating somebody's pain. And it's a great point to consider the pain tolerance changes because of medications and also exercise and the chronicity of the condition.
Right. So I think considering that, if a patient comes to me, especially with a chronic pain issue, it's something that the history taking along with the outcome measures is something that I focus on primarily, because then I can actually refer the patient to different disciplines, including in the past, I've done a referral to a physiatrist, to a massage therapist, to chiropractors. There are so many people that can be involved, especially in case of a chronic pain patient. And as Dr. Sidharth has covered the exercise or the physical therapy or exercise aspect, blending these all the techniques or integrating them together is just going to help reduce the pain, or it's going to trigger those pain mechanisms. So I think we can surely discuss about that, but I think I personally practice yoga, and I blend physiotherapy and yoga a lot. So I think yoga and physiotherapy will surely benefit, or has benefited, a number of my patients. Personally, I use other techniques like essential oils. I use some other techniques, like even modalities, right? So there are studies on that, whether it's the TENS machine or the IFCs, they can be used for chronic pain. So just wanted to talk about that because it can be used, and it has been used in the past. So yes, I think those are the main points I wanted to talk about. I think we pretty much covered everything else. So
great. Dr. Bhushan, any question or any comment in particular which you want to discuss with Dr. Shweta? Otherwise, we have.
I think she covered most of the things, and then if anybody else also has any ideas or
questions or some, I think, some comments from the audience as well. So now, guys, those of you who want to ask anything, please, this is your chance. Just put it out in the chat box, and I will take it. Meanwhile, we have one comment from Dr. Harne, and he's a senior colleague, and I think he has put his question on what type of exercise should we advise to the patient who is going regularly to the gym and is having acute non-radicular pain. That is probably he wants to ask about what type of. I think there are various answers to this question, but I'll slightly rephrase it and I'll ask Dr. Bhushan and Dr. Shweta on how what you will want to prescribe to them.
Yes.
So I think Dr. Shweta can also go, but I will just say that there's never like one exercise that we can say that it works for everybody. It's important to assess, find out what is weak, what is tight, what is what is contributing to the pain, and then you have this toolbox where you have all these different exercises, and then you pick and choose what works best, what you think is best fit. And I'll let Dr. Shweta also talk about that. Yeah.
Yes, I think that's a very broad answer. I think he's covered the gist of it. What I normally do is I evaluate the hips and the unevenness, like if the pelvis is uneven or malalignment, basically, I should say, then we have to correct that first. As a therapist, I would correct that first. Second is what profession they are, whoever the pain is, right? So if they are sitting for too long, their hip flexors are going to be too tight. So they have to stretch their hip flexors. That is the second thing. And of course, the third thing is McKenzie. And I believe in McKenzie, it works. And if they have radicular pain, the number of times you do McKenzie, you will see the centralization and the pain is going to surely reduce for sure. So.
Great. So in my practice, I would, align all this with the patient's beliefs, because, many times, if God forbid, Dr. Shweta is to come to me, so I'm going to prescribe her yoga, because I know that she believes in yoga, and it's very much easier for her to kind of go with that. And that's how we kind of make it easy for the patient. So if somebody who is very stiff, they have never been on the floor, and tell them, okay, from tomorrow you're going to do yoga, and then they'll just say, yeah, okay, sure. And then probably the next time you'll see that their pain has not gone. So why I put up all those different types of exercises, was because of various reasons. The prominent being that you have to mix and match with the patient, and also just as Dr. Bhushan said, that you have to see whether they are stiff, or whether there is some imbalance, or whether it's an occupational thing. So I have seen various patients who had a very occupational thing. Like one of them was a bus conductor, so he always used to climb down like this, okay, always on the left side. And he used to just, with one hand was in the air, always with holding something, and then always on one side. So naturally there has to be an imbalance if he does not train the other muscles, and that will be reflected in a weird sort of a pain, which will of course not show up in the scans, in the MRI, and will be off and on with the meds. So there's no clear-cut answer. You have to start with the most probable, and then do hit and trial till you hit the thing, and then discharge the patient from your treatment with a kind of a long-term prescription of this exercise, I think. What it is for me. Great. So let's go to the next question. Dr. Snehal is asking, I think this question is for me probably. How many days of physio do you advise for radicular pain before going to pain intervention? So I will typically send my patient to my physio colleague. When they give up, that's the time when I probably will do the intervention. If they don't give up, they're seeing progress, they're seeing good results, or if the patient is also happy. So then acute disc, the phase is 6 weeks. If you can wait for 6 weeks without anything, the pain is mostly going to settle. Now, if I often tell my patient that if you are not too eager, you can tolerate the pain, you can, do, many people say that hum seh lenge, or we will just tolerate it out. And my tolerance is great. I do not want even an injection. I do not want anything, doctor. I don't want medication, nothing. So especially for those patients, but also for each and every one, we can tell them that this is a acute phase, and unless it's an extruded disc which is not going to settle on its own, mostly the acute phase will go away in 6 weeks with or without treatment. If you want to shorten it, reduce the future chances, it's better you go with the treatment. And it often is decided as a team by me, my physical therapist, and also the patient. The patient is a very important part of the decision-making process. Do you have any other thoughts, Dr. Shweta or Dr. Bhushan, or is the same with you as well?
I think I agree with the 6 weeks period, and it depends on the patient. So I think the patient should be, is the judge, or they should be their symptoms. We should be deciding depending on the patient's symptoms. So that's absolutely fine.
Great. So there's another comment from Dr. Snehal. She's asking, during the acute phase of pain, do you advise basic stretching exercises of spine? So would you like to take this, Dr. Shweta or Dr. Bhushan, anybody?
Sure. So during the acute phase of pain, yes. So there are various kinds of stretching, like you said. It depends on
whatever. Yeah.
Right. So I will first ask what your pain level is. Stretching actually has to be done in the acute phase so that we get the blood circulation going, and maybe no ballistic stretching, no dynamic stretching, but you do have to do 15 to 30 seconds of a stretch so that you can release those that lactic acid, that the pain receptor, the pain out of it, right? So the muscle tightness needs to be going down. So acute phase, to answer your question, yes, we can do stretching in the acute phase, but only isolated muscles which are guided by the therapist.
Great. So
one thing that I'd just like to point out is we all sort of always love a yes and no answer to things. And with exercise, or with, I think, healthcare in general, there's no like a strict, black and white situation. There's always a gray area. So it's not like, you can do, you cannot do. You have to find that right patient. You have to find what fits, what tailors, and what works. What works for somebody else might not work with like a different patient. And especially with chronic pain, you have to always tailor and individualize your treatment.
I think that's a point well taken. And we move to the next question. It's more of the relation to the psychological aspect. So this is from Dr. Thirumala, and he's asking, what is your take on CBT? That is a cognitive behavioral therapy with patients on chronic back pain, and the fear of the patients when they read about the reports and get worried about it. So what is the experience? Again, this is a general question, quite tangent to our topic, but let's take it because most of the patients will have some sort of psychological apprehensions to the treatment. So what's your take on it, Dr. Shweta or Dr. Bhushan? Anyone?
So I'll let Dr. Shweta talk more because she's probably dealt with patients, but I think this is also where both like physicians and rehab specialists can work together in sort of calming down, or, like sort of taking ease the apprehension about what they see in the results. And you have to also realize that the more chronic the condition gets, you have to take care that there are all these emotional and cognitive responses that are, developing in these patients. So you have to account that, not just sort of say that, no, you are faking it, this is not real. Because there is also a lot of, like here in the US, like steps are being taken to avoid the sort of the stigma approach there. What you are talking about, your pain is not real. You are you want medications. That's why you are increasing the pain. So it's important to listen to the patients, and also sort of talking to them, and other therapy approaches like cognitive behavioral therapy are great approaches if you feel that it is right fit for the patient that way.
Yes. Yes, and I think I recently just worked with a patient who was very apprehensive to see her MRI. But I think it's something that we do as a physiotherapist. I sometimes call myself as a psychotherapist. Like, I actually have to explain and sit down with the patient to, first talk and listen to the patient's anxiety and any concern. So that's almost like I talk about that cognitive side or behavioral side. First I treat that, and then treat her physical or movement functional issues. So I think it's very important to address that, considering that chronic pain is also emotional pain, mental pain, and physical pain. So I would surely do that.
Sure. So we agree, we all of us agree that some amount of counseling is necessary at the primary level only. Okay. Of course, we have our colleagues from the psychology departments who help us, but some sort of basic counseling is always welcome. So we move to the next question, which is from Dr. Niharika Bhide. She's asking, how does the strengthening protocol differ between acute and chronic phases?
That's a good question, actually. So I can surely, answer. Maybe Bhushan can back me up on that. So acute phase is, of course, in the first typically 6 weeks that we're going to work with the acute patient. And then any pain that can last after 12 weeks is considered as a chronic pain. I mean, the strengthening protocol will differ. In the acute phase, we are just starting to engage the core, doing some basic strengthening. As per the recent guidelines, as per the, ACSM guidelines, they do recommend even moderate to higher intensity exercises for resistance training, even for patients with lower back pain, unless it is a surgical protocol or it's different completely. But in case of chronic, we are actually targeting multiple comprehensive techniques, like Dr. Sidharth has mentioned. So the strengthening will include a lot of repetitions when it comes to chronic. In case of acute, it is more of focused on the muscle. So I think that's what I think. So.
Yeah, that's a great point. And I think two other things that I'll add is it's important to sort of evaluate when you're giving these strengthening protocols is how much physical activity does a patient do when they come to you. If nobody's ever exercised in their lives before, then you cannot just say that do so much. You have to gradually do like 2 exercises, then increase repetitions. And the one difference also being with acute, you should sort of take care of the pain. So sometimes with acute patients, the pain dictates what you do in terms of exercise. And chronic pain patients, you can sort of, once you get to the phase where chronic phase, they have exercised, their muscles are probably working, and then you just have to make sure they do it every day so that they don't sort of lose their like imbalance, muscle imbalance gets worse, and the like posture and things, all those things are very important because the strength has to come up by that time.
Great. Now we move to the last question, and then we'll probably end this session. Thank you all for the great discussion. So this question is from, so let me check out. We have one more question, which is from Dr. Snehal. So her question is to Dr. Bhushan and Dr. Shweta, and she asks, what percentage of your patients actually go for a pain intervention? Because she wants to say that so many patients, they complain that they wasted so much time in pain. So what percentage of patients they go to pain, and which are the patients we do straight away mark for an interventional pain procedure or for some sort of a surgery? I'm not talking about the red flags. I'm not talking about the paralysis or the deficits, and all those patients will definitely go to the surgeons or to the pain physicians themselves. But what about where do you draw the line?
I think if I have to say, like out of 10 patients, maybe I have maybe 3 to 4 patients would do that. I think most of them would recover with physical therapy, with certain techniques that we are doing. if some of them is it just, it can be, it is related to consistency, carryover, and how much they are able to follow through, so that it doesn't become so chronic and they have to then do other techniques. So I think that's what, in my experience, that's my answer.
Sure.
Yeah, and I think I'll just add one thing. This is where again patient education about telling them that this acute condition has happened to you, which has not happened in a day. It has been over time. Like chronic stress on your body, and your low back has probably like given up. So it doesn't get better in one day. So you have to talk to the patients and tell them that this takes time. You have to be patient with your exercises and your pain medications. And then if it doesn't work out, then consulting with your orthopedic surgeon, physicians, you can come up with other interventions as well. That's my experience that I've seen, but I don't know if there's any number on how many, like Dr. Shweta said. So yeah.
So I have a slightly, you can say, allied but different take on it. Next time, just try explaining to the patient that the current, maybe not on the first session, but maybe on the second or the third session or something like that, because by then they have an idea of how their condition is progressing. This is what I do with my patients who come to me with acute on chronic pain. So most of my patients, say about 90% are chronic patients. Sometimes, rarely, some acute patient who's purely an acute patient comes to me, but more, since I am a spine and pain physician, so most of my patients are already having this problem for quite some time, at least say 12 weeks by definition. So I explained to them that if your current pain levels are tolerable, this is what your natural progression of your disease is. I give them the timelines, which are very well established. Like I mentioned about the acute phase of a disc, for example, will last for say 6 weeks. And if they are very comfortable with their current situation, they want to carry on, drag on, I don't even offer them a procedure. But if I get a patient who wants to resume his work, and putting tomorrow he wants to be active, and I have an intervention which can help him do that, I will offer them on that particular day, and then let them make a choice. Doing exercise or doing physical therapy actually is not a choice. They have to do it any which ways. However, doing a procedure, or even in some cases a surgery, will be a choice. Let me give you an example. If it's a sports person or a big film star with a surgery, with a recommendation for surgery, and he wants to do it, so then he will obviously be ready to take a risk also, because his whole career will depend on it. If he loses 4 matches or 5 movies, then that's a big loss for him, and he will want to probably take a risk. On the other hand, if some 60-year-old retired person wants to take it easy and wait for some time while he tries to recover using the rehabilitation methods, which are surely going to make him do some progress, but they may be slow, so that's a way for him to go. So I think this is what I practice, and I think this is one way wherein some of us can practice. Of course, some of us can be very aggressive, but then the patient will obviously make their own choices. It's not he will not die. It's about the suffering, and that's what for my pain clinic and many of our pain clinics, we include this tagline that your suffering is optional, but the pain is inevitable. So I think that sums up my approach to this. Great. So I think thank you all for the nice discussion. Thank you, Dr. Bhushan, for the great presentation. Thank you, Dr. Shweta, for the moderation and sparing your time. It was indeed a great discussion. Thank you all the attendees. Now we move on to the last slide. So this is about the next steps. The secret of getting things done is to act. So guys, those of you who are here for the first time, just join our mailing list. We have the WhatsApp group in the chat and email. Your suggestions, comments, are all welcome. And just drop in a mail to me at mumbaiPainSchool@gmail.com. Keep learning. This is our second journal club of this year. 2022 is no different. COVID or no COVID, just keep learning. With these words, I end the talk. Thank you very much. Have a great time.
Thank you.
Thank you.